Welcome to the Coder's Blueprint, your structured guide to mastering the 2026 ICD-10-CM Coding Guidelines. In this series, we'll walk through the essential rules that shape accurate, compliant, and clinically meaningful coding. Whether you're new to coding or sharpening your expertise, this guide is designed to build your confidence step by step. Disclosure: this presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. This guide is organized into 5 modules, moving from foundational principles to more complex scenarios. We'll start with the core coding process, then explore diagnosis interpretation, advanced code relationships, documentation nuances, and finally apply everything in a real-world case study. Let's begin building your coding mastery. Every accurate ICD-10-CM code begins with the same 2-step process. First, locate the diagnostic term in the alphabetic index. Then, and this part is non-negotiable, verify the code in the tabular list. The index points you in the right direction, but the tabular gives you the full code, including laterality, extensions, and instructional notes. Never code directly from the index alone. ICD-10-CM requires us to code to the highest level of detail supported by the documentation. A 3-character code is only valid when it isn't subdivided. If a 7th character is required, the code is incomplete without it. Auditors look closely at specificity, so always capture the most precise code available. When laterality is available, use it. Right, left, or bilateral. If no bilateral code exists, assign separate codes for each side. And remember, unspecified laterality should only be used when documentation truly doesn't clarify the side and clarification isn't possible. Not every encounter ends with a confirmed diagnosis, and that's completely acceptable. When the provider hasn't established a definitive condition, it's appropriate to code the signs and symptoms. Chapter 18 is your primary source for these codes, and we'll review that chapter in upcoming videos. Unspecified codes also have a valid place. They're used when the provider doesn't yet have enough clinical information to be more specific. The rule is simple: code what is known at the time of the encounter. Some symptoms are considered an expected part of a disease process. These shouldn't be coded separately. But if a symptom isn't routinely associated with the condition, or it represents a unique issue, then it deserves its own code. A helpful question to ask is this expected? If not, code it. When a condition is documented as both acute and chronic, and both appear as separate subentries in the alphabetic index, assign both codes. The acute or subacute code is always sequenced first. This reflects the immediate clinical concern. Combination codes allow us to capture multiple elements, such as 2 diagnoses, a diagnosis with a manifestation, or a diagnosis with a complication, all in one code. If the combination code fully describes the condition, use it alone. Only add additional codes when the combination code lacks necessary detail. Some conditions require more than one code to tell the full story. You'll see instructions like, use additional code, or code first. These sequencing notes are mandatory. They ensure the underlying cause and its effects are coded in the correct order. Sequelae represent residual conditions that remain after the acute phase of an illness or injury has ended. You'll assign 2 codes. First, the current residual condition, and second, the sequela code that identifies the original cause. The acute code is never used with a sequela. Focus on what the patient is experiencing today. When a condition is described as impending or threatened, check the alphabetic index. If a specific subterm exists, code it. If not, code the underlying condition. Borderline diagnoses are coded as confirmed unless the classification provides a specific borderline option, such as borderline diabetes. Most diagnoses must come from the patient's provider. But there are exceptions where documentation from other clinicians can be used, such as BMI, pressure ulcer stage, coma scale, NIHSS, SDOH, and laterality. Just remember, the associated diagnosis must still be documented by the provider. For syndromes, always follow the alphabetic index first. If no guidance exists, code the documented manifestations. For complications of care, there must be a clear cause and effect relationship between the care provided and the condition. The word complication doesn't have to appear, the documentation just needs to support the link. In natural disaster scenarios, sequencing matters. Start with the injury code. Next, assign the external cause code for the cataclysmic event, such as X37.0 for a hurricane, which takes priority over other external cause codes. Then add any additional external cause codes needed to fully describe the situation. Finally, use Z codes to capture important context, such as homelessness, inadequate housing, or equipment dependence during power failure. Accurate coding rests on 3 pillars. First, relentless specificity, always code to the highest level of detail supported by the documentation. Second, unwavering adherence to process, follow the index to tabular method, and all instructional notes. And third, the art of interpretation, understanding the clinical story and translating it into clean, compliant data. Thank you for joining me on this walkthrough of ICD-10-CM Guidelines. Coding isn't just about rules, it's about telling the patient's story with accuracy, clarity, and integrity. As you continue practicing, remember that every code you assign contributes to quality data, better patient care, and stronger healthcare systems. Keep learning, stay curious, and continue building your coding mastery.